This session is recorded on YouTube and streamed live on the IFA Facebook page. It is now my honor to introduce IFA Secretary General, Dr. Jane Barrett.
Thank you very much, Sheila. Good morning, good afternoon, and good evening. Dr. David Nabarro, Special Envoy to the Director General of WHO, said, and probably said several times, in the face of the COVID pandemic, we are only as strong as the weakest of us. However, the same could be and has been said about those populations most vulnerable pre-COVID in the context of infectious diseases, and those are namely older people and those with chronic conditions. The International Federation on Ageing has for almost 10 years now prioritised the need to improve uptake rates of adult vaccination, which are generally shamefully low in most countries, in the context of healthy ageing and maintaining an improved function. As we all know now, vaccination is one of the most successful public health measures of modern times, preventing up to 3 million deaths worldwide every year, and some say second only to clean water. Older people and those with chronic conditions such as HIV, heart disease, lung disease, and complement deficiencies are at higher risk of developing complications from vaccine-preventable diseases than the general population. Civil society has critically needed in the development of effective policy. And we are those organisations that fight for the rights of the constituents that they represent. And there are also times when we must just listen, and we must reach across the aisle and develop collaborations and partnerships with decision makers. It is rare that we have the opportunity to listen to members of Parliament, and we are very delighted today to have this opportunity. To listen to MPPs Dr. Philippa Whitford and Mr. Virendra Sharma on the approaches that the All-Party Parliamentary Group on Vaccinations for All and the APPG on the vulnerable group to pandemics. The purpose of this listening session, and uncomfortably titled, Is There a Gold Standard for Adult Vaccination in the UK?, is to improve understanding of the importance of routine vaccinations and also to learn some lessons. So let me have the honour now of introducing Dr. Philippa Whitford. Prior to being an MP, Dr. Whitford was a breast cancer surgeon for over 30 years. And just prior to our discussion, I asked Philippa whether she missed, her surgery. And the answer is, of course, yes. But on the flip side, Dr. Whitford also said, if not me, who, in becoming an MP. Dr. Whitford, during her time as a breast cancer surgeon, led in the local redesign projects and established the initial breast cancer audit standards for Scotland. In the early 1990s, she spent 16 months as a medical volunteer in a UN hospital in Gaza. In 2016, she established a training project along with medical aid for Palestinians to improve treatment for women with breast cancer who live in the West Bank and Gaza. Having been an active campaigner for Scottish independence in 2014 referendum, Dr. Whitford was elected as MP for Central Asia. You're going to have to help me, Philippa, with the pronunciation of that. In 2015. Since that time, she has served in the SNP Westminster Health Spokesman since 2015 and is now also the SNP spokesperson on Europe. You can imagine that Dr. Whitford's time is scarce, and we are very grateful that she really has stepped outside, her normal duties, as an MP. But just from the two very brief conversations that I've had, it's inspiring to listen to a person that's been at the heart of patient care and now is representing constituents, in the United Kingdom. So the floor is yours. Thank you very much, Dr. Whitford.
Thank you very much, and it's Ayrshire, and that's probably one of the easier place names to pronounce in Scotland. But thank you for the invitation. When people talk of vaccination, we tend to think about young children, but vaccines are not just for babies. While childhood vaccination is of course very important, we're now using vaccines throughout the course of life and vaccinating teenagers, adults with underlying medical conditions, and the elderly. The COVID-19 vaccination program, however, is the first time we have attempted to vaccinate the entire adult population, but the use of vaccine in adults is only going to grow in the future. As well as vaccinating teenagers against meningitis, they also receive the HPV vaccine to prevent infection with human papillomavirus, which causes cervical cancer. While this is an indirect method of preventing cancer, research work is already ongoing to develop specific vaccines which would cause the immune system to attack and destroy cancer cells. Vaccines also have a key role to play in dealing with antimicrobial resistance to antibiotics. While most vaccines are against viral diseases like measles and polio, there are also vaccines against bacterial infections. Pneumovax can prevent pneumococcal chest infections and pneumonia, and therefore decrease the use of antibiotics, which are already becoming more and more compromised. As a surgeon, I recognize the threat of such resistance and the types of complex surgery which would simply become impossible in a post-antibiotic era. There have been no new classes of antibiotics developed in the last 30 years, and each new drug is lasting a shorter and shorter time before resistance develops. This is something we thankfully don't see with vaccines, despite decades of use. For vaccines to prevent infectious diseases at a population level, we need high uptake to achieve what's called herd immunity, whereby the pathogen is unable to find enough unvaccinated people to which it can spread and sustain an epidemic. That way, even those who can't be vaccinated are protected. This is a term the public are now familiar with because of COVID-19, but it should only be considered as part of a vaccination strategy, not based on the idea of just letting a disease rip through the population, especially one with a high death rate and when natural immunity to coronavirus can be relatively short-lived. The World Health Organization described the key to achieving high vaccine uptake among any age group as coming down to the 3 C's. Tackling complacency about the risk of disease, building confidence in the safety and effectiveness of vaccines, and providing vaccination as conveniently as possible. All 3 are closely linked. Tackling complacency and building confidence are critical, as people are only likely to bother taking a vaccine for an illness they consider important, and only if they trust its safety and effectiveness. It is then important to make vaccination as convenient as possible to ensure access does not become a barrier, particularly for those who live rurally, some ethnic communities, or marginalized groups such as those who are homeless. COVID highlights that it is in all our interests for everyone to have easy access to the vaccine, to stop the spread of the disease, and also to allow health services to get back to providing other important treatments. After a year of being trapped in our houses, complacency regarding COVID has not been a major problem in the UK's vaccination programme so far. However, as we've seen with COVID restrictions, this may become more of a challenge among younger adults, many of whom do not recognise the threat of long COVID to themselves or the danger they might pose to a vulnerable loved one. Complacency is already recognised as a contributor to the falling uptake of childhood vaccinations, as younger parents have never seen a case of polio or diphtheria. And despite measles causing the death and disability of many thousands of children across the world every year, most people in the UK consider it a minor illness. The combination of this complacency, along with a loss of confidence, caused all vaccination rates to plummet just over 20 years ago when Andrew Wakefield published his erroneous claims that the MMR vaccine caused autism. While his research has been refuted and he has been struck off the medical register, the whole episode contributed to some people's reluctance to take any vaccine, and along with that, a resurgence of measles. Measles is one of the most infectious viral diseases, with an R0 number of 11, reflecting the average number of people infected by each person with the virus. This means a very high level of vaccination of about 95% is required to achieve herd immunity. Despite a degree of recovery in the uptake, we've seen vaccination rates across Europe and the US remain below this threshold, which led to serious outbreaks of measles in 2019, when the UK also lost its measles elimination status. Catch-up programs have been required for adults who were unvaccinated due to the original collapse in uptake around the time of the scandal. The original strain of COVID had an R0 of about 3, meaning herd immunity could be achieved by vaccinating about 2/3 of the population. However, the new B117 Kent variant, which is now the dominant strain in the UK and rapidly spreading across the world, is much more infectious as well as much more deadly. It is putting younger adults in hospital and is also now causing problems even for primary school children. To achieve herd immunity against this strain, 3/4 of the population would need to develop functioning immunity. Surveys carried out last year prior to the development of COVID vaccines suggested uptake might be quite low, with about 1/3 of people saying they'd be reluctant to take them. Yet uptake has been astronomical, with more than 95% of those in the UK over 60 years being vaccinated so far. The reasons given by those taking part in the original surveys were focused around vaccine safety rather than any complacency regarding the dangers of COVID. This shows that the importance of general health education was able to raise that uptake from what might have only been languishing in the 60% range up to over 90%. It shows the need to explain how these vaccines were developed so quickly. Never has the public known more about viruses, vaccines, or epidemiology than over this last year. But it's also vital not to be dismissive of concerns about serious side effects, such as the recent cases of cerebral venous sinus thrombosis, as this actually shows the safety monitoring systems are able to detect and investigate even rare occurrences. I feel we should not use the term vaccine hesitancy to cover all those who don't immediately leap forward and roll their sleeves up. There are those who are vaccine reluctant, ranging from those who refuse to take vaccines themselves to others who actively campaign against anyone else taking vaccines. However, vaccine hesitancy is a perfectly normal reaction. It just means that someone has questions that they want answered. Whether that's about vaccines that have been developed in less than a year compared to the more normal 5+ years, or because vaccination is the first serious medical decision they will make regarding their new baby. It's important that people can ask any and all questions and get answers from a trusted source. This is the best approach to anti-vaccine claims, not to publicize them through further large myth-busting campaigns, but to ensure that people understand there are no stupid questions and any concern can be raised. Naturally, the corollary of this is that healthcare staff must have access to the information and training to help them provide the answers. Prior to COVID, one of the largest and most important adult vaccination programs was the annual flu campaign, which, despite thousands of deaths every winter, often had a very poor uptake, and which even in the UK has been drifting downwards year after year. Despite attempts to improve convenient access through community pharmacies and other community settings, it has been plagued by the complacency of people confusing real influenza with the common minor viral illnesses that we experience each winter. Unfortunately, many elderly people believe the vaccine won't work or could even give them influenza. However, in the UK, the record-breaking uptake of the flu vaccine last winter shows what can be achieved by investing in greater publicity and making a concerted effort around the programme. Overall, uptake increased from about 70 to 80%, and uptake among those with other health conditions rose from a dismal 40% to make it over 50% for the first time. However, the record-breaking uptake of COVID vaccination among those normally offered the flu jab suggests there is potential to achieve further improvements in the future. One key advantage the UK has in promoting good vaccine uptake is the NHS, or National Health Service. Unlike in the US and many other countries, all routine vaccines are free and are usually provided via the local family doctor or community staff. This means cost is no barrier and makes accessing vaccines fairly convenient for most people. However, the health benefits of vaccination are so significant, there should be more home vaccination through health visitors and community nurses to support the housebound and new parents who may still struggle to get to their family doctor's practice by public transport. Importantly, the fact there is no money transaction between the doctor or nurse and their patient also improves vaccine confidence, as there's no perceived conflict of interest or suspicion of a profit motive when they promote vaccination. This is likely to contribute to the incredibly high levels of trust in advice from health professionals that has been identified in surveys carried out by Public Health England and other organisations. While digital information from NHS bodies also score highly as trusted sources, they have to compete online with sensationalist claims by anti-vaccine groups. The UK government are working with social media platforms to take down harmful content and prevent the profiteering from such material through advertising. While most people outside the UK, and indeed many in the media here, talk about the NHS, there are in fact 4 separate health services, one in each of the UK nations. While COVID vaccines have been purchased on a 4-nation basis, and the prioritisation advice of the Joint Committee on Vaccination and Immunization has been used UK-wide, the programmes themselves have been delivered separately by each of the devolved health services. While getting comparable data can be a challenge, this allows some comparison of different policies or approaches. One area where Scotland differed was in the intense initial focus on vaccination in care homes, as residents had been the most vulnerable victims throughout the pandemic. This was the #1 priority group of the JCVI, who estimated that 1 care home resident could be saved for every 20 who were vaccinated. The challenge, however, was that the first vaccine to become available last December was the Pfizer one, which required to be kept at -70 degrees centigrade. The UK licensing body, the MHRA, initially required it be handled throughout the entire process, from receipt of delivery to injection, by a single legal entity, which could be held legally responsible for maintaining the cold chain throughout. As Scotland still has a unified public NHS, rather than separate trusts and providers within a healthcare market as in England, it was possible to start delivering the vaccine to care home residents from mid-December. Having given 50% of residents their first dose by the start of the year, Scotland saw a dramatic fall in COVID deaths in care homes throughout January, with almost 90% also now having had their second dose. We've seen a 97% drop in COVID deaths in care homes over the last 3 months. Vaccine uptake by care home residents is now very high across all 4 UK nations, but where there is still a major difference, north and south of the border, is among care home staff. While there is still a struggle to get vaccination much above 75% of care home staff in England, over 99% of those in Scotland have now taken the vaccine. We faced exactly the same difficulties as our colleagues elsewhere in the UK, but there was recognition of the need to make a concerted effort to achieve high uptake among staff as well as residents if care home outbreaks were to be prevented. Seeing some of their residents die of COVID meant that complacency was not an issue, but the Scottish Government became aware of a concerted campaign of disinformation being targeted at care home staff. Therefore, they arranged 3 webinars with the Director of NHS Scotland, our Chief Medical Officer, and his deputy. These were open Q&A sessions for care home staff at which they could simply raise any question or concern. And this quickly resulted in improving uptake. With regards convenience, it was national policy in Scotland that staff were vaccinated along with residents whenever vaccination teams visited a care home. While this was done by some family doctors and teams in England, it was not universal, and many care homes reported difficulty in their staff accessing a vaccination appointment. However, uptake isn't just improved by the greater convenience of vaccinating staff at their place of work, but also the contribution of solidarity. Being offered the vaccine along with the vulnerable residents they care for and along with their colleagues encouraged a greater willingness to be vaccinated. This coverage, with 97% of care home residents and over 99% of staff now vaccinated, has led to a 98% reduction in cases, along with the 97% reduction in deaths. Having seen the care home deaths, the terrible toll of those deaths throughout the last year, this is major progress. Since the start of this year, Scotland now has half the population rate of care home deaths compared with England and Wales. And this shows that a concerted, focused effort on tackling complacency, providing enough information to build confidence in the vaccine and making access easy really can drive up vaccine acceptance and drive down infections. Never has such a large-scale adult vaccination been attempted. And it's important that after COVID, we remember the lessons of the successes and challenges of these programs and use them to improve routine vaccination programs in the future, whether for children or adults. There are still ongoing challenges to be faced, as good overall vaccine rates can mask poor uptake in certain areas or among specific ethnic communities. It's therefore important that health services are aware of their detailed local vaccination data and ensure all information is provided in multiple languages and accessible formats to ensure inclusion of those for whom English is not their first language or who have a sensory or learning disability. They must also reach out and recruit champions within every community to listen to local concerns, answer questions, and promote the importance and safety of vaccines. Multiple delivery approaches should be considered to make accessing them as easy as possible for everyone. Scotland is an incredibly rural country, so we have paramedics and ambulance staff taking vaccine buses and converted ambulances around the rural areas and vaccinating villages and our 70 inhabited islands one at a time. The other major challenge is global access to vaccines. Through the Gavi program and the polio eradication initiative, access to childhood vaccination has improved dramatically in low-income countries. But many routine programs have been disrupted by the pandemic, and cuts to international aid threaten to derail progress. This time last year, there was a lot of fine talk about the COVID pandemic being a global crisis, which required countries to work together on a global response. Despite the donations of money to the World Health Organization's COVAX program, rich countries have bought up 90% of the world's COVID vaccine supplies. So while we are celebrating the proportion of our populations who've been vaccinated, many poorer countries have been unable to access any vaccine at all. Already here and in Europe, the narrative is turning to talk of vaccine passports to allow tourist travel this summer. But an alternative would have been to help ensure access to vaccines and other COVID technology for all countries, so the pandemic could be brought under control more quickly. The use of such passports domestically would limit some people's access to society and risk widening inequality and exclusion. Just accepting that COVID will continue to circulate and kill people in poorer countries is unethical, but it also risks the emergence of yet more dangerous variants, some of which could be vaccine resistant, as we already see with the South African variant. And these could undermine the progress made in countries like the UK. We should remember the basic principle of dealing with such a dangerous infectious disease on a pandemic scale. No one is safe until everyone is safe. Vaccines have enormous potential to prevent illness throughout the life course, from eliminating or even eradicating life-threatening childhood diseases to reducing the threat of cancer or influenza among older people. But there is no childhood vaccine against poverty or poor housing, nor can we vaccinate the elderly against loneliness and isolation. Healthy aging begins at birth, and therefore as health professionals or politicians, or in my case both, we have to widen our view from focusing on the management or treatment of illness to the promotion of wellness. COVID has brought our society and economy to a shuddering halt, and it will not simply rebound. We will have to invest money, time, and energy into the post-pandemic recovery, and therefore have the opportunity to choose what kind of society we want to rebuild. We know that we must tackle climate change and have a more circular economy by 2030 if we're not going to eat the planet. So we should take the chance not to build back, but to build forward to a fairer and more sustainable well-being economy, where governments consider the impact of all their policy decisions on the physical, mental, social, and environmental well-being of every citizen. We are all lucky enough to be living longer, but we are not yet aging well. While vaccines can help prevent illness, we should set our ambition much higher for everyone to be able to look forward to being healthy, active, and engaged in our later years. Thank you.
Thank you very much, Dr. Whitford. And, as expected, inspiring, but also very rich with information. We do have Mr. Sharma, who's going to come on soon, but as you said, he's in question time. And so I'm going to take the liberty of asking a couple of questions. And I will also call on Ken Bluestone from Age International to follow up my question. So, Dr. Whitford, we have been most concerned about, the different WHO targets for immunisation coverage. If we just think about influenza, we know that the target for children is 90%, for adults, 75%. And so just in terms of the new quality and outcomes framework indicators for routine immunisation, it's a very positive step forward for encouraging the system to improve the uptake rates. But it seems as though that the targets for adult immunisation just are not on par with childhood immunisations. And one of the indicators is for shingles, the target is to achieve just 50 to 60% coverage. Should we be aiming for parity? If we talk about vaccination throughout life, so, what are your views about that?
Well, I think the higher targets were set around children because in some ways it's kind of easier. We have a lot of engagement with children in their very early years around child health. So we have easy access to them. And then the vaccines that are delivered in school, we also at least have easy access to speak to them, to send home information. It's much harder with adults. And the problem up until COVID is that really governments have taken quite a passive approach. So yeah, we'll put out a couple of little adverts, you can come and get your flu jab here, or, oh, now you're a certain age, we're going to mention shingles. But until COVID, there has never been the same drive and campaigning and public awareness around driving that uptake higher. And I think what COVID should do is throw down the gauntlet to say that literally, I mean, you know, above 60 in Scotland, all the levels are 99%. So if we can achieve that with COVID, yes, we achieved over 80% for the first time with flu because there was more discussion about it. But maybe we need to actually take some of the structures we've had to set up for COVID and some of that kind of publicity and focus and start putting that into the winter influenza, into the shingles campaigns to reduce both suffering and indeed deaths. I mean, a bad influenza winter will take tens of thousands of people's lives, and yet we don't have the same focus and discussion. So while the COVID achievement is really positive, I think it definitely puts a challenge to us for the future.
And of course, pneumococcal pneumonia and also the emerging trend of pertussis. But I do also have to say civil society has been lagging way behind, you know, particularly in our field in ageing. There are not too many organisations in this field that prioritise adult vaccination in the context of function. So we really do have to pick up our game as well. I really believe it's time for partnerships and collaboration because many of our organisations can really reach, you know, older people in the community. So I welcome Ken Bluestone for your question, Ken, because it really does have, you know, a little bit of a connection to my question. Please go on.
Oh, thanks so much, Jane. And it's good to see you again, Dr. Whitford. I was really wanting to focus on how much ageist attitudes might contribute to some of this. You know, at the beginning of the pandemic, we heard media pundits suggesting that the deaths of older people could be a cull of older people, a positive thing. And so I'm wondering, do you think that the attitudes towards older people have changed over this period of time of the pandemic? Has this is improved? Do you think that this is affected as well, people's access to vaccines, and not just vaccines, I suppose, other forms of prevention, including even simply gathering the data necessary on older people? So just how much do ageist attitudes affect, and how are things improving?
Well, I think quite a lot of that is cultural. Unfortunately, in the UK and quite a lot of Europe, Northern Europe particularly, I would say we've been influenced from America of the culture of youth and beauty. We have a tendency to value youth and beauty and celebrity much more than we value age and wisdom. If you look at Mediterranean cultures, and when I lived in Gaza, you know, actually it was the elderly who were valued and venerated. So I think there is an underlying ageist or ageism to our culture that was certainly kind of influencing that. How much that has really changed, I think, is hard to say, and how much is more, if you like, a reaction to guilt and to kind of media challenge. People can recognize the importance of elderly people in their lives, their parents, their grandparents, their elderly aunts and uncles who've been part of their entire life story. But I think that we need more of a culture change. And I think we should be trying to see that for ourselves. As I say, we know risks of dementia and many other things are literally laid down virtually prior to birth, but certainly in childhood. And while some people say, oh yes, everyone gets old, I know as a breast cancer surgeon, no, not everyone gets old. You know, I mean, really, it is an honor and a luxury to get old. But we need to be achieving a much better old age. You know, by the age of 50, we're starting to collect our illnesses. And not only does that put a pressure on the NHS in helping us manage them, it also limits our experience of our older age or of our retirement. And so I think we need to start having that ambition of having that high quality older age for all of us and therefore for each other. But I think part of that, we would need that cultural change to recognize that experience, knowledge, wisdom is actually an incredible resource. So we shouldn't write people off, we should value them. And we do need to make sure that they are active members of our community. A lot of our elderly people, and we've seen it in the pandemic, can end up isolated and lonely. And of course, that then contributes to failing health. So I'm not yet convinced that we've seen a genuine change in that culture from the pandemic. I think it is more, if you like, politicians or policymakers or health services have had to respond. I think we've further to go on changing the culture.
Thank you very much, Dr. Whitford. I'm just going to try and identify, I believe from Sheila that Mr. Sharma has just joined us. But so Sheila, is that correct?
Someone joined with the title IFA speaker. So I just wanted to see if it was Mr. Sharma.
Okay, Mr. Sharma, are you with us? All right, so I will go on and ask you another question while Sheila just searches for Mr. Sharma. So we understand that the government has postponed the publication of its long-term vaccine strategy, which is entirely understandable. Is this an opportunity for an ambitious and meaningful targets for adult immunisation to ensure the protection of the most vulnerable? So does it change, does the pandemic change, the ambitious nature of this vaccine strategy? Because many countries, are eagerly watching, the rollout of this strategy. Would you like to comment on that?
Well, I think it should. I have no information as to whether it will, but it would be utterly negligent if we did not take the learning both from our mistakes, but also from the new systems, whether it's data systems or delivery, how we have really gone out with the vaccine into communities, how we have engaged community leaders in ethnic communities to try to get a high uptake using religious settings, churches, mosques, leisure centers, anything to make that vaccine as accessible for people. So I would be very disappointed if when it came forward, it was just what was already on the conveyor belt. Certainly in Scotland, there's been a lot of innovation around the management of the vaccines, particularly obviously the logistical challenges around the cold chain for Pfizer meant that you needed to know where the vaccines were, you needed to know how they were being handled. And so there is a much stronger national network in Scotland. We had already moved some of the vaccination responsibility from GPs to our local health boards. Healthcare in Scotland is delivered by a health board who are responsible for all of the hospital and community and primary care within an area, who then work through our integrated boards on social care with our local government. So it was very easy for us to identify, which care homes we had, how many residents they had, how many staff. So I think there will be aspects of that will be strengthened, and I would certainly expect the learning of that. I think looking back at the surveys of last year that suggested a third or more of people wouldn't take the vaccine, and yet looking at the incredible uptake we've achieved, I think does importantly show the importance of education and discussion. People heard about, well, how did we develop vaccines in less than a year without cutting safety corners? How does it work? What does the virus mean? What does the vaccine mean? So I think education, keeping vaccination on the agenda and making it as easy as possible by reaching out needs to impact on the strategies of all governments going forward.
I'm just going to ask Erica Dar to come forward and ask her question. She's from AARP. But as a prelude to Erica's question, some of IFA's work has clearly taught us that public health messages in general assume a certain level of health literacy. And, COVID, as Dr. Nabarro has said, the poorest of the poor are paying the highest price. So with that as context, Erica, please we welcome you to ask Dr. Whitford your question.
Thank you, Jane, and thank you, Dr. Whitford, for this really substantive presentation. You talked about rural populations in your presentation. My question to you is, at the UN, we talk about leave no one behind. You also talked about delivery services, and you referenced in-home. My question to you is, did the UK and in their GP policies and reaching people go to persons with disabilities in their homes? How did you handle that sector of the population? Thank you.
Yes, I mean, there has been home vaccination in all 4 UK nations. Obviously, I have more detail in the health board area that I live in, but that was organised quite simply through sending out district nurses from the local GP surgeries. They obviously had their list of housebound people or people with disability, but it was quite easy for, you know, even I think of friends of my elderly mother who the husband was housebound, but, you know, the wife was able to phone and say, you know, can you just do me at the same time? Yeah, no problem. So there was quite a low bar set for people who needed vaccination at home, certainly here in my area. And then for some of the marginalized groups, it was working with homeless charities, through homeless shelters, with those who support rough sleepers, where they would go out and actually vaccinate. But you then also have to look at what can be the barriers in the other direction. And one of the issues in England is that the health service agreed to share a certain amount of data with the Home Office. And obviously that can make people who are asylum seekers or who may no longer be official immigrants anxious about giving their data or coming forward. And I think that's the importance, that it needs to be clear to people that all of us see the importance that everyone can be vaccinated. So there have been different approaches taken to make sure that we reached out. And as I said, I mean, Scotland's actually half the size of England, but with 8.2% of the UK population. So while, you know, Glasgow, Edinburgh, Aberdeen, we've got some big cities, we have vast areas of, you know, mountain and heath and small roads and villages and 70 inhabited islands. So having a rural policy of mobile, bringing the vaccination to a village and then vaccinating that entire village, or to an island and vaccinating that entire island, were policies we had to put in place quite early on to make sure that we were reaching out.
I just wanted to thank you for that response, because I was quite, and have been quite, critical about the changing vaccine strategies where I live in Ontario and across Canada. And so I was struck by your response to my criticism, which was well-founded, that, you know, we actually have to, this is a dynamic process, and that we really have to be responsive to changes in the environment. So would you like to just have a comment on that?
Well, right at the start, because there was a lot of, the kind of vaccine program was very public, was being used in the media a lot. And because England was going more for big vaccination centres early on, going on the age groups rather than the care homes, you know, I was dragged onto the media literally every other day for about 3.5 weeks to explain why Scotland's vaccination programme was failing. Whereas we kept explaining, we are focusing on the care homes at the moment because that's where people are dying, and that's what we need to do first. The other thing is, you know, even at a push, you could probably only say that Scotland has 4 cities, and in 3 of them, we set up mass vaccination centres. That would be completely useless for most people in Scotland. And therefore, you know, England is much more densely populated. And I think that's the importance of, it doesn't need to be the same in every health board area or local government area or province in Canada. You need to actually be looking at what is the layout, what's the demographics of my area, but also what is the population? If you've got a particularly strong ethnic population, are you making sure the information is in their home language? Are you engaging champions to discuss any barriers that you may not understand, but that you could help with. So I think the idea of uniformity isn't important. The idea of us all aiming for the same principle, that everyone should have easy access to this vaccine, is important. And one of the problems at the moment is, despite all the warm words last spring, we're reverting to a, I'm all right, Jack, we're doing fine. The fact that other countries can't get vaccine in the global south, we're not giving enough attention to that. And as I say, it's not just the ethical issue of it, it will eventually pose a threat to us if we generate more of the virus variants as we see in South Africa and Brazil.
Look, you're doing a stellar job, Dr. Whitford. We still haven't got Mr. Sharma, but I'm sure he's coming on. So bear with us. Dr. Cynthia Stewart is the main representative for IFA at the United Nations. Cynthia, welcome.
Thank you. I echo the accolades for this incredible presentation, Dr. Whitford. But in your unique position as a physician and member of Parliament, do you believe that that we can shift the paradigm to end ageism and be inclusive of older persons and ensure the less developed countries truly have equal access? Do you think there will be the political will to do that?
I think, unfortunately, right at the moment in the UK, that's hard to see. As chair of the All-Party Group on Vaccinations for All, I've written to the Prime Minister with some cross-party colleagues because they plan a really significant cut to funding for the global polio eradication initiative. And the UK has, for a long time, been one of the key funders of Gavi and GPEI. So, in economic terms for the UK, the amount of money will not have a major impact, but it will have a major impact on many vaccination projects in the global south and in low and middle income countries. And I think that's just completely the wrong message that we should be going. We should be following up on the statements that we made last year of recognizing we're all in this together and no one is safe until everyone is safe. But in a general sense of supporting vaccination, that's not what we're seeing. Tackling ageism, and this will be something, in the low and middle income countries, we actually see often more respect, as I said, for older people, more valuing of older family members. But I think that where we need to tackle that most in Europe, the US, Canada, and the UK is particularly within the media. I think that we are seeing a little bit of role models who are older, but I think we need much more of that. It's the media that has very much promoted that perfectly toned young body, that, photoshopped beauty, etc., instead of recognizing that someone who has been working for 40 or 50 years, even beyond retirement, has incredible knowledge to share with the younger generation. And I think we've ended up a little bit around things like child protection and so on, and don't talk to strangers. We've actually created barriers between the children in our community and older people in our community that didn't exist when I was young. Through my local church, we would have visited older people who lived alone and made them a cup of tea and sat and had a chat with them. Whereas now children are taught, even if an elderly person on a park bench says hello, oh, don't talk to them. So I think we've a lot of challenges, but I think some of that has to be done outside politics. It's cultural, it's media, and all of us need to tackle it head on. I think, unfortunately, where we are politically at Westminster at the moment, I'm not expecting a great revolutionary change, but all of us have to keep plugging away for it. It won't happen if we don't ask.
Okay, thank you. Dr. Olive Bryanton, welcome, Olive. You with us?
I am with you.
Good. Please ask your question of Dr. Whitford.
Dr. Whitford, this has been a wonderful presentation. Thank you so much. My question is, how much impact has the media had on the uptake of vaccines? I know it's had a huge impact on ageism in the wrong way.
Well, I think certainly in the UK, as you can see, the incredible uptake of the vaccine has been very positive, and I think, you know, good news begets good news. So when people see others coming forward, I think that also promotes confidence. I'm concerned what's going to happen when we're trying to vaccinate some of the younger cohorts, because we already see, as I said, you know, they're not always sticking to the COVID restrictions because they've been given the impression that COVID can't harm them. And I think that's dangerous. But I think what we've seen is simply having vaccination being discussed in mainstream media and the education that has come from that and putting it on the agenda has definitely contributed to that higher uptake. And so I think we need not sensationalism and not the kind of, you know, I mean, I remember saying at the beginning of this, if the Prime Minister calls our vaccine program world beating, we're in real trouble, because that phrase was used for everything from apps to whatever in the first year. But it has been. And I think that it is important that you are bringing these things forward and having just very simple discussions in plain English. What the public have shown is that if you put out information, they can understand it. Now, as a doctor, I would, of course, like to see more basic health education at school. You know, dealing with patients where you're having to start at 101 because people don't know their way around their own body has always been a challenge. And I think we could look to raise the understanding of people when they're at school so that that carries on into adult age. But I think what the pandemic has shown is that if you bring forward simple explanations, infographics, if you have calm discussion about the issues and honest discussion, not over-promising, honest discussion about what vaccines can and can't do, then actually people will come forward. And I think this will be challenging as we move into the younger cohorts. We may need to change our approach, but I think it can be done. And I think, horrendous as the pandemic has been, I think there is a lot of learning that we owe to everyone who suffered from it to not lose. We need to make sure that learning is taken forward and contributes to better health in the future.
Thank you very much, Dr. Whitford, and also Dr. Bryant. And you'll be delighted, Philippa, that Mr. Sharma has arrived. So you can just take a rest and have a cup of tea. Welcome, Mr. Sharma. And thank you very much for being part of this important listening session. Perhaps if I can just take a moment to introduce you to our colleagues here today. What struck me in your bio was that, your arrival in the UK Parliament was the end of one long chapter of public service and the beginning of another. And you were first elected as Member of Parliament in the Ealing Southall by-election. So tell me how to say it, Mr. Sharma.
You're right, Ealing Southall by-election.
All right, Ealing
Southall.
You know, my Australian mouth and accent doesn't get around some of these words, so my apologies. By-election on the 19th of July in 2007. Since 2007, and having been elected 4 times, you were re-elected with a majority of over 22,000, the largest for any MP. And in 2019, with more than 60% of all votes cast. I think that says something about your public service. You also talked about the importance of your late father. And, many of us on this call today are in the field of ageing. And we recognise that this year is the UN Decade of Healthy Ageing, the beginning of it. So that's certainly important. Your father was a prominent political leader of Punjab state in India and a political and social reformer. You married with a grown, yeah, you are married. No, yes, of course you are married. You have a grown-up son and daughter and 3 grandchildren. And before I get too more confusing to myself, please, we're grateful that you have been able to join us from Parliament, and the floor is yours, sir.
Thank you very much, and thank you for that lovely introduction. Sometimes pronunciations, I face it every day. Don't worry about that. I face it every day and find it more amusing rather than any kind of embarrassment. I enjoy that. I'm delighted to be here with you today, and thank you for inviting me to this listening session focused on strengthening advocacy efforts around the common agenda of improving vaccination rates and advocating for those most at risk of vaccine preventable diseases, specifically older adults and those with chronic diseases. I'm pleased to be here with so many of you and to share the platform with my colleague in the Parliament, Dr. Philippa Whitford, chair of the APPG on Vaccinations for All. I can without doubt say that while I missed a lot of what was said earlier, Dr. Whitford will have been both insightful and studied in her listening and speaking. As chair of the All-Party Parliamentary Group on Vulnerable Groups to Pandemics, who have been advocating for greater priority for prevention, treatment, and support for vulnerable groups since September last year, I believe focusing on the vaccination of vulnerable groups is vitally important now with COVID-19 and in the future. The COVID-19 pandemic has placed significant further stress on the most vulnerable groups in our society, with many facing difficulty due to a lack of clear, concise, and up-to-date government guidance on shielding and some feeling new barriers to accessing treatment. Our work has set out to provide an effective voice in Parliament for those vulnerable groups. Elderly people too have felt the worst effects of the pandemic, sharing an elevated risk of complications from COVID-19 and facing delays to treatments for underlying conditions or even preventive vaccinations. The initial success of the vaccination program has provided us all with hope for an end to the current COVID-19 outbreak and an end to lockdowns in the UK. Is the time permits, or you would like me to stop?
No, go right ahead.
No, okay. So sorry, I thought you come back and there's a time limit.
No, no.
I won't take long time to say what I would like to say. Outbreak and end to lockdowns in the UK. However, with the vaccination program not yet complete and an end to shielding regulations, we are still fighting to ensure that the safety of all vulnerable people is not compromised. The government's prevention is better than cure vision, outlined at the end of 2018. Its pledge to launch a vaccination strategy and the recent formation of the UK Health Security Agency are clear steps in the right direction for placing the vaccination system at the forefront of the UK health policy and preparing for future pandemics. However, continued advocacy for older adults and vulnerable groups is necessary to ensure that their voices are heard in Parliament. This morning, I must take that. This morning, I asked the Secretary of State for Health how his department is working to get vaccine messaging into the uncontacted communities. The Secretary of State thinks spokespeople, trusted voices in communities are of immense importance. In Leicester, they have secured community-staffed vaccination centers. This works for COVID-19. What does offer longer-term vaccination efforts? This won't be enough to continue to the vaccination effort after the pandemic, but at least there is a sense we need to act. The effects of pandemic and the way it has been handled by the government must be treated as a clear example of the need for a clear vaccination strategy for future pandemics, and we should learn to prioritize and advocate for the elderly and most vulnerable in our care plans. With this in mind, I want to offer a few insights from my own position as a member of parliament. With my own constituency, I have a direct sight into the lives of thousands. Those looking for health and to be vaccinated are not monolithic, nor are the concerns, and one solution will never suit them all. While the rate of COVID vaccination uptake amongst the British Indian population is high, and it remains better on average than the white British population, if only very slightly, the picture is not the same for all. British, Bangladeshi, and Black British people have a meaningfully higher hesitancy rate than the British average, as do some of those of Eastern European heritage. This hesitancy is caused by one thing, and most importantly, it is the failing of the system, not of the individuals. Suspicion in many BAME groups of the health establishments has for a long time been a healthy and learned behavior, one gained through years of systematic racism and outright violence in some cases. Groups with a low level of health literacy have often been denied good health care for years. The pressure is on us here to build a better system. We must institute ways of working that connect with those unsure of the system and make sure that system puts the care of the older, the poorer, and the more vulnerable at its heart, not just as an afterthought. The COVID-19 pandemic has shown us time after time the frailties of the system we have, but also the immense resilience it has as a whole. In the UK, the strength of the people that make healthcare work, not for profit, but as a calling, and around the world, millions of volunteers have answered the call for specialists and skills. As a member of the International Development Select Committee, my role is often to scrutinize some of the most important work our government does. Supporting the Sustainable Development Goals is a key part of how we judge value, but the UN principles of older persons have their place too. Healthy aging is an issue for all, the old and the young, and any good years lost unnecessarily are a waste and a tragedy. The value of vaccination has been writ large by the pandemic. Let us take the lessons learned, use the skills developed and the networks built, and turn them to other vaccination programs. I don't want to speak anymore. I want to listen. I want to hear your thoughts. Good policy making is done best with the most information, not the ideas I came here with, but the ones I take away from here. Thank you very much.
And thank you very much, Mr. Sharma. And I have no doubt as to the reason why you are elected with such a great majority. So certainly you have brought to the table, the clear understanding of the constituents that you represent and the importance of listening to their voices in the development of good policy. I'd like to kick off a question to both of you, and it's about austerity measures. The globe is under threat in terms of, the social and economic environment in which we live, both low and middle income countries and also high income countries. I do want to just pause here and also make note, Dr. Whitford, of your conversation about ethics and about jumping the queue and about high income countries who promised, funding and vaccines for low and middle income countries and COVID, and it's not happening. And so I think that that's a conversation that civil society needs to also have a strong voice. But in these times of austerity, and people in our field, fighting rhetorically for the rights of older people, it's very easy for funding decisions not to be across the life course, but to be focused on a younger population. And we hear it all the time. Well, they have so many more years to live than someone who's 70. So, how do we as civil society respond, to government's austerity measures where there will be cuts to programs that help build healthy ageing populations? So, Mr. Sharma, why don't you kick off that and then we'll go to Dr. Whitford.
It's a question which everybody asking every day, whether they are member of parliament or the person on the street who is waiting for that. I believe that all this issue of not only pandemic, but we are living in a global society now. So we have a responsibility for each other. If we want as a healthy community all over the world, we need to pool resources together to make sure. I'm 70 plus, so I don't want to be ignored as a wasted resource. I want it to be an asset to the society. So it means that everybody have a right, and the government and the institutions and all the civil societies and individuals have to work in partnership to make sure that everybody is protected, whether they are the young, which are the future generations, whether they are old, the past, but they can live together and they have to live together. So you cannot ignore one or the other. So you have to have a strategy and a working plan in partnership with the local communities to make sure that everybody is protected. So it's very difficult to say whether young against the old or old against the young. It's the society we're living in to make sure that they are protected and have a healthy society so that we can have a economic prosperity and the safety in the communities.
Okay, thank you. Dr. Whitford, your thoughts?
Well, I fear that we are going to be looking at another 5 to 10 years of austerity, and that's certainly what was signalled in the recent budget at Westminster. And that's why, when I was talking about a well-being economy, my call would be for a completely different approach. If you look at poverty in the UK, and we know that poverty is the biggest single driver of ill health, the change in child poverty, disabled poverty, pensioner poverty, it didn't come with the banking crash in 2008. It actually started in 2012. And that was actually when political decisions were made to cut funding, and to cut funding from the poorest and most vulnerable in society. And I think that is an absolute mistake. These are often the people who do not have a strong voice, certainly do not have a strong political voice, and therefore it seems easier to do. And what we have seen, certainly in the UK, and I'm sure it's the same in North America, that the people at the top, the people with vast wealth, have doubled or trebled their wealth over the last 10 years. And I really fear that if we go down this same mistake again of cutting services, of cutting funding, and welfare support to the poorest, then actually the gap is going to get worse. Obviously, Professor Michael Marmot wrote his first report in 2010, showing the gradient between the poorer, more vulnerable communities and the wealthier. While what we saw was an improvement in life expectancy for everyone, that gradient didn't change. And in actual fact, in the last couple of years, we've seen a drop in life expectancy for the poorest elderly women. You know, the girls born now into poor communities, we're actually expecting them to live a shorter time. That's an incredible setback. And so I fear that the UK government and many other governments are going to take a short-term approach to, oh, we need to pay all this money back. If we look at the earlier generations that came out of the Second World War with enormous debts, what they did in the UK was set up a welfare state, set up an NHS. They actually imagined bigger. They actually were more radical. And I feel that we need to do that, both from the kind of environment and sustainability point of view, but also from tackling the inequality, whether it's over age or whether it's around different communities. We need to recognize that the countries that are more equal, particularly the Nordic countries, they actually are more economically successful, more politically stable. And I think that that's where, you know, Virendra and I will need to be campaigning at a political level to try to get the government to not go round the same racetrack. And all of you who are in other countries will need to do the same. Otherwise, the global north is going to make exactly the same mistake they made in the last decade.
Yep, and words that we need to adhere to as civil society, you know, at a country level. So thank you. David Richardson, you've been populating the chat box quite a lot. So could you come forward and ask one of your questions to Dr. Whitford and Mr. Sharma, and perhaps tell us where you're from?
I'm from Canada. And yes, I guess I've been a little hyperactive this morning, and some of my questions may not be germane to the very question of vaccinations, but the most recent one I posted has to do with what I wonder whether there has been a general erosion of the sense of society, perhaps in favor of individualism, that makes it almost impossible to fight a problem like a pandemic because it requires a societal response. I wonder whether the two members of Parliament might want to comment on that, because it's certainly germane to the type of work you do.
And David, we like hyperactivity in the chat box, so continue. So perhaps Dr. Whitford, we'll kick off with you and then go to Mr. Sharma.
Well, I mean, I absolutely agree. As I talked about, this kind of promotion of celebrity, of beauty, of youth, all goes along with that. I think if you spend any time, as I've done, not just in Gaza, but involved in visiting AIDS projects in Kenya, Zambia, Tanzania, what you see that communities there often have that we've lost is that incredibly strong sense of community. You do see it in rural areas, you do see it on the islands here, but in big cities, you know, people can get disconnected, and certainly through media and the cultural promotion is all very much me first. I have to succeed, and if I have to trample over a few people to succeed, so what? So that does undermine it, and that is very much the argument around promoting well-being economics. Scotland was the founder of the Wellbeing Economy Global Governments Group, along with Iceland and New Zealand. They've already been joined by Finland and Wales. And my understanding is actually that there are members in the Canadian Parliament who are considering whether Canada would join that group of countries. There's also the Wellbeing Alliance, which involves more academics and researchers looking at how you could change your society so that you literally have that every level of government, every public body, and then from there promoted out into private companies would start to look at well-being. You know, GDP includes the proceeds of crime. That's a very bizarre way to measure the progress of your country. we know we can't afford to eat the planet, nor can we afford to cook the planet. So we need to have a change, but it's very difficult to change an economy or a society when it's running so fast like a speeding train. And what COVID has done is it has stopped us in our tracks. So as I said in my presentation, we will need to invest money, time, and energy to rebuild after COVID. And therefore, I feel there is really an opportunity at the moment to try and change that. But it needs to be in the media, it needs to be within politics, it needs to be within civil society, that we try to pull back to community and society rather than me, which is kind of what we've been promoting now for the last 30, 40 years.
And Mr. Sharma, any further comment?
Yeah, I fully agree with Philippa, her sentiments and the approach. I myself was born in a small village, migrated, so I understand the importance of the community cohesion. I understand the working in partnership. That's what I was using the term, that we don't need to be, we need to have the full potential of every citizen. But at the same time, it should not be influenced with the greed. It's not that I get everything, my family get everything. I don't care about the next door neighbor or in the community. We need to bring that spirit back where we support each other. We make sure that if I'm okay, I look after the others as well, so bring them back. So it's a working in partnership, bringing everybody together and making that old, if I use the term, old style community spirit, where the people were caring each other, supporting each other, helping each other, making sure that needs are met rather than their social status. So I fully feel that in the last few years, that I get everything, others I don't care, that idea has developed, which we need to bring back to it's not I, it's not me, it's us. We all need to progress in the society. One other thing is that it's important that if we want to have a healthy, successful, economically prosperous society, then you look at that health is the most important. If you are healthy, then you can contribute. If you are sick, then you cannot. So good health provisions, good economic training skills, making sure that everybody is skilled enough to contribute, then you have a healthy economy in the world or in the communities or in the society. So we need to make sure that we look after everybody in the city, every citizen, look after them on their health point of view, make sure that good education and the skilled education is there, and then we can have the better economy. You don't want the unhealthy economy, you want the healthy economy. Yes. So for that, we need to work together.
And of course, you know, we have one of the 4 action areas of the UN decade is age-friendly cities and communities. And I think there's different forms of that growing, but, you know, that is one of the vehicles that's across generation. We also know from the Global Report on Ageism that intergenerational activities are evidence against ageism. So we have 2 final comments, and then I'm going to ask Dr. Whitford and Mr. Sharma to actually give us some takeaway messages. So Ken Stone and also Margaret Mulligan. So Margaret, if you can just pose your question, then we'll go to Ken, then we'll go back to Philippa and Virendra. Margaret? Okay, we'll go to you, Ken. Thank you.
That's great. Thank you so much. And it's wonderful to see you again, Mr. Sharma. You touched in your last set of comments about a discussion that we were having on earlier, which was around the importance of changing attitudes and culture towards older people in the UK. As Jane just mentioned, the WHO has come out with a new global report, first ever global report on ageism. And what is very sad to say is that one of the things that is pointed out is that ageism, unfortunately, is endemic, actually, in almost in all parts of the world. Almost 1 in 2 people have ageist attitudes according to their research. But on a positive note, one of the things that we've learned is how you reframe these attitudes. One of the really powerful tools is through the UN structures and through creating a UN convention on the rights of older persons. We saw this happening with people with disabilities. And another positive thing that I put in the comment was the UN just had an open-ended working group meeting, which meets every year, to look at how to better protect the rights of older persons. And I'm really pleased to say that the UK government delegation said at that meeting that it would, in principle, support the creation of a new multilateral instrument. So this is something that is hugely welcome, and I think that we all have a part to play in the UK to get the government to actually take that step even further. But I just wanted to share that positive news with you.
Okay, thanks very much, Ken. So as we come towards the end of this important listening session, and it has been listening on all sides, hasn't it? You know, the sharing of knowledge, communication, also engagement, and finally tuned messages for civil society to be part of action going forward. So I'll kick off with you, Mr. Sharman. What are your takeaway messages for the audience here today?
I think that the most important is what I said earlier, that we need to change that attitude from me to us, rather than I and nothing more. We need to start it from the school days. We need to have in the education system where the children, for the future generations, the future leaders of the society, future citizens of the world, they need to understand the importance of working in partnership, working together, making sure that I live in an extended family, my grandchildren living with me, or I living with them at this stage. And I feel that they understand the better way of ageism, how they can work together, how they can support me as a grandparent. And then they learn from there. That takes out into the society as well. They see me struggling, then they see somebody on the street, they have the same attitude. Working closely, making sure in the school system, education system, also have the ways to educating the future generations to bring back the community spirit, what their rights are, what their responsibilities are, how best they can contribute into building up a healthy society. So I think that we need to look at all sides of it and working together. And I use the term again, which I regularly use, is working in partnership with the young and the old, poor and the rich, working together to make sure that we can bring the society which we love to see healthy, economically prosperous and peaceful.
Thank you very much, Mr. Sharma. Your closing comments, Dr. Whitford.
Well, I would agree with everything Virendra has said, and a lot of the discussion that we've had today. While the main theme was talking about vaccination, I think we can see how it fits in the much wider challenges of what kind of society we have, how we value people, and how we include people. And I would just add, one of the things that we've also lost in as well as the sense of community over the last 30 years or so, is a sense of enough, a sense of being satiated. You know, we have created such a consumerist society that, you know, our iPhone is no longer good enough. It's got to be the new model. We've got to throw away clothes and buy something else. So there are lots of things around the division of different groups within society, the way we consume, the way we don't share, that need tackled. And as I say, because everything has been brought to a halt by COVID, we will never have as good an opportunity as this again to step back, to look at what we really want. What kind of society do we want to live in by the end of this decade, and to actually aim forward for that. So we've seen things, many of us here in the UK will remember the Channel 4 programme of elderly people coming in and helping in a nursery or a primary school. We need to get the generations back together, the kind of barriers between them, or politicians setting one against the other. is not helpful. We actually need to recognize, as I said, that healthy aging begins when you're born. And therefore, it's important for the next generation how well they age, how well we look after them when they're young. It's important for those of us like me who are entering the third age that we are still included, that we can contribute what we've learned in our lives, and that we can be involved and not left isolated and lonely. So while vaccination, I think, is something that we can talk about and how it fits in and what it can achieve and the lessons we can learn, I think what we have all heard this morning is that the challenge is much broader than that. And whether we're a politician, an academic, in the WHO or in a civil society group, I think all of us have a responsibility to try and move the dial and change those attitudes.
So Dr. Whitford and Mr. Sharma, I would do this session an injustice to continue a conversation with my summary, because I think both of you have very succinctly, pulled together the most important key messages. The IFA was very proud to convene this listening session because I truly believe that civil society at times needs to do a lot more listening than talking. So we thank both of you for being here today, particularly because of your busy schedules. I'd also like to thank Sheila Amri for leading this project, and also Berenice Anaya and the IFA staff. So stay safe and stay well. And we look forward to working with organisations in the United Kingdom, to ensure that a comprehensive vaccination throughout life strategy is in place. So warm regards to you all. Thank you.
Thank you very much.
Thank you.